Friends, welcome back to our program Weekends with the Maestro program, episode 6. This is going to be a very exciting program because we have one of the biggest Maestro we have had till today with us. My request is, we'll have some small meeting etiquettes. That is, please mute your audio so that we'll not have any disturbance. And if you have a query, don't hesitate. Please raise your hand. Okay. And if you have any query, you can also message directly in the chat box, so that will be discussed. Okay, we'll pause our video, the presentation, and we will discuss. And nevertheless, we are going to have a final discussion in the end also. Okay, we'll have that. And we have no financial conflict of interest. Our sponsors are Basaveshwara Medical College and Hospital, Chitradurga, and Karnataka ENT Hospital Research Center in Chitradurga, and Champions Education Medical Society of my place. A lot of friends have been asking me about this class. We did an introductory class, but because of my involvement in some emergency activity, we had to postpone the remaining classes. So that we are going to restart again from 20th February. Thank you very much for showing keen interest and writing to me about this, asking me about this class. We'll definitely come back to you. Really, your interest is our motivation. Okay. With this, friends, next week's program, that is episode 7 of Weekend with Maestro, we are going to have a topic on endoscopic tympanoplasty. Okay, a lot of participants, they asked me about this topic. So we have one of the senior most surgeon who has a lot of experience with endoscopic tympanoplasty. He is going to be there. So with this, I welcome our Maestro of this week, none other than our president of EOI, Dr. Bharathi ma'am, a senior friend since long time. I'll tell you, I am a deep admirer of madam. I'll tell you one incident. The first person whom I've seen operating juvenile nasopharyngeal angiofibroma endoscopically was Bharathi ma'am. That was when? That was in 2004-5 when I first relocated, to Karnataka after having a lot of short stints abroad as well as other states. Okay, and that was that was really amazing work. Nobody had started doing angiofibromas endoscopically that time. That was a great show, ma'am. See, ma'am is a senior professor, and also she is a former head of the department at Department of ENT-Head and Neck Surgery at JSS Medical College. Instead of me narrating her story, her CV, I think we should talk to her and we should hear from her own mouth. Madam, welcome to this program and this platform.
Thank you.
Ma'am, I would like to hear from your mouth, like, your journey, how you started, from where you started your undergraduate education, and how you reach where you are today now.
Yeah. Thank you, Dr. Prahlada.
Yes, ma'am.
Actually, I'm a simple surgeon who stays at Mysore. That's a second tier city. And I'm attached to JSS Medical College. For the past 29 years, I'm here working at all grades. I joined as junior resident. Before that, I did my post-graduation from Bangalore Medical College. And then I did my fellowship in head and neck oncology in Kidwa Institute of Oncology, Bangalore, and then joined here. In between, I went to Tata for my further training in head and neck oncology. But because we are attached to medical college, I do all ENT surgeries. It's not me. I've not made myself great. It is all my friends who surround me, like Dr. Prahlada, Dr. Deepak, many other who supported me and who gave the, the encouraging words. Like he said, you are the one. So that encourages your colleague to come up with their work to. It's always, step by step, you climb the ladder. So each encouraging words from my colleagues, I don't tell that I've already climbed the ladder. I could put few steps ahead of what I was 29 years back. And then I have achieved. And I do everything because, as I told you, I'm attached. But majority of my work is in head and neck as well as skull base. And then everything, like, all airways and otology work. And I'm an undergraduate as well as postgraduate teacher. And then many of my postgraduates who pass out, they're really happy because they get exposed to 360 of ENT.
Yes, ma'am. True.
So
I get to meet a lot of your postgraduates, and really they are very highly appreciative of you, ma'am. I mean, I think they're really blessing to have a teacher like you at JSS Medical College.
yeah, thank you.
Yes,
Like,
ma'am. I know. I
thing,
see that you have a
yeah.
huge number of publications. That's another credit. But what I am specifically interested, I know that you are a BC Roy awardee. That is one of the most prestigious award one can get, as a doctor in India. But what is more interesting for me is you are one of the nominee for that Margaret F. Butler
Yeah.
for outstanding mentor of women in head and neck cancer. What is this about? Could you tell us so that
actually, she's
we
a
can,
head and neck oncologist in American and under American head and neck oncology. They have this like award, like whoever
okay.
the head and neck like I don't tell it's the other gender, like the
Yeah.
females who have excelled themselves in the head and neck and who are trained the head and neck. So many of my postgraduates they have done MCH in head and neck oncology. One is doing robotics in head and neck oncology at Rajiv Gandhi
Okay.
Oncology Center, Delhi.
Yes.
So many of them get inspired.
Yeah.
And they start head and neck programs, so that I was one of the nominee.
Yeah.
And publications, still, that is the one thing I lack because I don't have the habit of sitting and writing. Maybe now
we all have that issue.
Now it's time for me
big,
to go and do it.
Yes. Okay.
And the research, okay, little bit because these days I'm doing it. We have come up with the one mobile app for hearing.
Okay.
You can check your hearing. I think in another 15 days, like we have already done, and the Chief Minister of Karnataka launched it. It will be in the Play Store, JSS Shravana Mitra.
Okay.
So that's one of the things. And I think ours is the first app in India. Actually, there are apps which are designed by other countries.
Yes.
But Indian, ours is the first app. It's nice, like you can do both air conduction and bone conduction. And once it is on the Play Store, I'll send the link to everyone.
Okay. Yeah, that's a mobile app.
Yeah, it's a mobile
for hearing
app.
assessment. No, that's very interesting. I think this will be very handy. But we do a lot of camps outside.
You can use
in peripheries.
We have done validation also.
Yeah, this will be very useful. Definitely, that is something a very innovative app. It's going to be. That's great, ma'am. So your focus of your work is mainly the head and neck cancer surgery. That's what you love to do. Yeah. Okay. Correct. That's very nice, ma'am. So you mentioned a lot of friends. Okay, really great honor for me.
But one thing I want to tell you, Dr. Prahlad, our training in ENT, which all the postgraduates should have more of head and neck training, so that they become bold. They a general ENT, good, but when they see the blood, when they are doing even the minimal Maestro, if at all they open up the sinus or something, they get scared and they'll stop there. They'll not do full work. Head and neck training is a must. Yes. Everyone should get it, even if the center where they are.
I think you are in a position now. You're in such a position, that you can change things now. Really, you can revolutionize the training, ENT head and neck surgery, the way it's happening in the country, and really you're in a position to motivate all junior colleagues to do that. We look forward to have a lot of programs in this regard from you, ma'am, this year.
Thank
and the next 1 year ahead. We're going to have a very exciting year for AOI consent. Look forward for that, ma'am. So, ma'am, with this, I think we should move on to the show. Our show. You have already made you this thing co-host. So I will stop sharing my presentation. Let the show begin. You can share your presentation now.
Thank you, Dr. Prahlad.
Yes, ma'am.
Again, I tell you, friends like you who has made me what I am today.
Ma'am, I want to ask you a curious question. Friends, okay, we are all there. We have to motivate each other. you name some teachers whom you see who feel like, who have left a deep impact on you, whom you would like to emulate, because we all look at teachers, yeah, during your career.
Actually, for me, for head and neck, it was Dr. Ashok Shenoy,
Okay,
and then
good,
Dave,
great.
Dave, and
Okay.
then Nanjundappa sir for his, very sincere person, and
Yeah,
slow and steady wins the race. That I learned from
he's a
him.
lovely person, a
Yeah,
fantastic
and you should
surgeon.
never, fast surgery is not the answer. It is slow and how neat you do the surgery. That's all.
Yeah, that's right.
And then for otology, it's Sir Mahadeva, sir. I don't think anyone can.
Fantastic, ma'am. Really blessed,
Yeah.
blessed to have.
And the other thing, you all made me what I am. And the other thing is Dr. Satish and Chanti. I mean, it's always, you have a good competition. Like when somebody can do it, why not you can do it?
Yes,
And
certainly.
the institutes, great institutes like AIMS, like you are from PGI.
Yes.
You people are so like from the prestigious institute. Yes, we don't have the facility, but we have the brains like equal. So why not make use of it and do something in the setup where you are?
Yes, that's very important. I think you're given a wonderful message to begin with. It's like a TNT bomb. This all junior colleagues should take this message. This is one of the important message you're given to begin with, ma'am. Yeah, with this we'll start, ma'am. We are eager to listen to you. Yeah.
Thank you. So Dr. Prahlada asked me to do the talk on the superficial parotidectomy. Yeah, it's a common surgery of the salivary glands, which we all do. So my way of talking today, my thing is, first I'll just share my PPT. This is how the flow of thought will be there. Introduction, epidemiology, anatomy, pathology, clinical features, investigation, literature review I have not put here, management, and then unedited video. If that video doesn't work, I have edited videos also. So we can go through it. Now, let's start. Neoplasms of the salivary glands are rare. They account for 3 to 6% of all the tumors of the head and neck region. But still, we need to know because they come to you. Cancers of the salivary gland occur with an incidence of approximately 2.5 to 3 cases per 1 lakh per year. And the facial, see, the parotid gland surgery, if not for the facial now, I don't think we would have bothered much. If the tumor is there, go, remove the tumor, remove the parotid gland, come out. It wouldn't have been so, interesting, so fascinating for us, and like time consuming also. And it's the facial now which makes us, it's a center to parotid surgery for both surgeon and patient, making the surgery very demanding and challenging. And this is what comes whenever we take consent for all these surgeries of the parotid surgeries. We tell the patient, the facial now is there. And if at all, it's not like when we're talking about the superficial parotidectomy, usually it's done for the benign. And if not for the permanent, you'll have at least temporary paresis, even though you have saved the nerve, you have identified the nerve, either because of the traction you use or because of the type of facial nerve you have, you might have some paresis, which is there, which might recover. So that with that consent, we always go in. Epidemiology, it constitutes about, I already told you, 80% of the lesions are seen in parotid gland, of which 80% are benign. Pleomorphic adenoma is the most common benign neoplasm, followed by Warthin's tumor. This is the thing. And associated risk factors. Genetic, yes, 8q12 gene translocation, then pleomorphic adenoma 1, pleomorphic adenoma gene 1 is there on 8q12 gene translocation, and it acts on the IGF and WNT pathways. And 12q, 14, 15, HMGN gene, which functions as transcription regulator. Then HERS2 amplification also is seen, and CTD-NB1 mutation. And if at all, exposure to the radiation, yes, there is 4.5 5-fold increase in the incidence of salivary gland cancer and 2.6-fold increase of benign tumors among people exposed to low-dose scalp irradiation when compared with the matched controls. This is a study by Moran et al. Anatomy. The parotid gland is the largest salivary gland. It's wrapped in the parotid space situated behind the rami of the mandible. Each gland is divided into superficial and deep lobe by the retromandibular vein and the facial nerve. So that means it's an arbitrary division of the gland by the retromandibular vein and the facial nerve. 80% constitute the superficial lobe and 20% is the deep lobe. So we have already come out with 380%. Now, deep lobe extends through the stylomandibular tunnel, which is bounded by the mandibular rami and posteriorly by the stylomandibular ligament. Now, I told you facial nerve is an important structure which has made parotid gland surgery, which has given importance to the parotid gland. So there is various types of anastomosis or the rami or the branching of the facial nerve. Is it important? Yes, it's very important to know what type the branching the facial nerve has. Okay, yes, it comes out from the stylomastoid foramen, and then the main trunk is 5 to 10 millimeter in length, and then it divides into temporozygomatic and then the cervical gland. Now again, the various division occurs. Okay, these divisions. What is important is whether these divisions, they directly go like this or they have ramifications, okay, in between, like, one sending the connection to the other. Why this is important is whenever you have a ramification, if at all you injure the buccal branch, if at all the ramification is there, you injure here, and this is already there, so that will supply it, okay. So this is how the type of facial nerve to know it's important. Whereas in this, there are no interconnecting ramifications. You can see all are straight buccal branch, then marginal mandibular, cervical, zygomatic, temporal. So here, if at all you injure this, the patient is going to have the involvement of the angle of the mouth here, then marginal mandibular is the depressor angle will be paralyzed, then cervical, like that. So this is the only importance. Now, before Katz and Catalano had 5 classifications, now the recent one, there are 6. So this is what is important. These are the various ramifications you can see. This is how the divisions are there. Now, histogenesis, multicellular theory, each neoplasm arising from different cell type. Bicellular theory, origin from the 2 types of cells, that is excretory and intercalated. Now, radio imaging plays a very important role. And you all know parotid is interspersed with fat. Normal CT, the attenuation is more for fat and less of a muscle. In MRI, high intensity on T1 and low to intermediate on T2. And contrast will show the content of the gland. And here you can see the deep lobe, the superficial lobe. The salivary gland tumors are classified by the World Health Organization Classification of Salivary Gland Tumors 2017, which is further divided as benign and malignant. You can see all this. These are the non-neoplastic epithelial lesions, and these are the benign tumors, because today the topic is superficial parotidectomy. So these are all the indications for our superficial parotidectomy. And uncertain malignant potential. Then we have the malignant tumors, mucoepidermoid carcinoma, which is common, then the ethnic cell carcinoma, then the adenocystic carcinoma, like in that order of frequency I'm telling. Then we have the salivary duct carcinoma, myoepithelial carcinoma, carcinoma X, pleomorphic adenoma, and carcinosarcoma. Now, coming to the pleomorphic adenoma, which we commonly see regularly, it's the most common tumor between the age of 40 to 50 years, common in females. Okay, 80% of occurs in the parotid gland and 0.8% it is bilateral. Gross, like you have an irregular, and it is not smooth surface, it has a bosselated surface and grayish blue on cut surface, uneven capsule. Histopathology is as a mixture of ductal, mesenchymal, myoepithelial cells. That's why we call it as pleomorphic. Pleomorphic is multiple. Then Warden's tumor. These are the papillary cystadenoma lymphomatosum, and tumor is made up of glandular and cystic structure with the bilayer epithelial lining. It's the second most common. It's common in males, and usually it is not even 40 to 50, more than 50 years. And it is common in the tail of the parotid. And the Warthin's tumor are commonly seen with patients who are with smoking. Okay, around 8 folds increase in the patients with smoking and radiation in the past. Gross well circumscribed, partly cystic and solid on cut surface, and sharp demarcated line cystic spaces here. See, whenever we do these cases, we have to cut the tumor and see the surface, how it looks. Mucoepidermoid carcinoma, it's the most common malignant tumor of the salivary gland. Incidence is 29 to 45. 80 to 90% occur in the parotid gland. Malignant glandular epithelium neoplasm, and it's common in males. Age is 40 to 50 years. Gross, smooth surface, often cystic, white, pink on cut surface with well-defined. Histopathology made up of 3 types of cells: mucin secreting, intermediate, and epidermoid. High-grade lesions have a higher incidence of nodal positivity, surgical and locoregional recurrence, distant metastasis, advanced disease, and worse survival rates. These are all with the high grade. Treatment is surgical resection. Post-operative irradiation is indicated whenever you have the positive margins or with intermediate and the high-grade tumors and nodal metastasis is there. 5, 10, 15-year survival rates reported as 56, 27, and 7.1 respectively. This is the grading system of the mucoepidermoid carcinoma. I will not go in detail about this. Adenocystic carcinoma. The only thing is this common in submandibular. We need to know that it is neural invasion is there. Perineural spread will occur, and basaloid histological type. 10% of non-squamous carcinoma of the head and neck, and the 3 types are the cribriform, beta prognosis, tubular 35%, and then we have the solid 21%. This has the worst prognosis. Actinic cell carcinoma, 15% of malignant parotid gland neoplasm, and second most common parotid malignancy in children. It's a low-grade malignancy, 4 histological types: solid, microcystic, papillary, follicular, and nodal metastasis in 16%. Treatment is surgical resection without neck dissection. Carcinoma X pleomorphic adenoma. Okay, that accounts for 3 to 12% of the salivary gland tumors, and 755 rise in parotid gland, and 75%, sorry. 3 to 4% rate of malignant transformation. That was like if at all it recurs, if you have done surgery for pleomorphic adenoma, you have left the pseudopods, and then if it recurs, 3 to 4% rate of malignant transformation, and 5-year survival pattern is 30%. And one thing is, whenever we have the recurrence, it's very difficult for us to go in and then facial now preservation also. So always in the first go, the pleomorphic adenoma should be taken up properly. Salivary duct carcinoma, 61 to 65 parotid tumors, high grade 1.6% of parotid tumors, high grade aggressive tumor. Squamous cell carcinoma, primary parotid squamous cell carcinoma is very rare, usually spread from ear, skin, or adjacent structure, aerodigestive tract. Exclude high grade MEC by past stain, and that is mucoepidermoid carcinoma by past stain, and 50% nodal metastasis is there. Aggressive local surgery with neck dissection followed by radiotherapy. Parotid lymphoma, you all know that within the parotid gland we have the intraglandular lymph nodes also. So you can have the lymphomas here. Either it can have intraglandular or malt lymphoma occur in the parotid. 90% of the salivary gland lymphomas occur in the parotid. Non-Hodgkin's lymphoma B type. And this is one where we need to do the core biopsy. Chemoradiation is primary modality. Surgery has a role in malt lymphoma. Staging, I'll not go in detail about it. This is the TNM classification. What are the clinical features? Usually, if at all we take pleomorphic adenoma, it's a slow growing, painless swelling. Either you can see in the preauricular region or in the retromandibular space, and then it lifts. The classical signing of lifting up of the ear lobule, whenever you see, you always think of parotid swelling. Whereas if at all the lymph node is there, upper jugular digastric lymph node is enlarged, it will not push your ear lobule up. And then if at all it is a Wardin's tumor, usually it's the tail of the parotid, that is here it's involved. Facial palsy, skin involvement, lymphadenopathy in case of malignant. All this like sudden increase in the size of the swelling, which is there for past 4 years, 3 years, and then associated with pain and skin involvement or facial palsy or lymphadenopathy, then you think of malignant transformation. And sometimes these tumors, whenever they're for a long time, they can cause ductal obstruction symptom also. When deep lobe is involved, then it can present as parapharyngeal space tumor, oral fullness, dysphagia, hot potato voice, then obstructive sleep apnea and trismus. This already I told you. Clinical examination, size, location, appearance, and then before going for facial nerve function, you examine the opening of the parotid duct also, okay, Stenson's duct, and then you do the facial nerve examination, neck examination, and other cranial nerve examination. And whenever you have a parapharyngeal, that is deep lobe of the parotid or minor salivary gland tumor, then you can see when the oropharyngeal examination, the soft palate and the tonsil is pushed medially, okay? Whereas the retrostyloid or supra-aortic parapharyngeal space tumors, they are seen in the lateral pharyngeal wall behind the posterior pillar, okay? Your soft palate and the tonsil will not be pushed medially. They will be pushed anteriorly. Whereas with parapharyngeal space, deep lobe of the tumor extending to the parapharyngeal space, then the soft palate and the tonsil is pushed medially. Oropharyngeal exam and palpation to rule out the deep lobe involvement. Investigation, okay, whenever we see, first we get the radio imaging, that is ultrasonogram. And then if at all the facility is there, best is to go after ultrasonogram, then ultrasonogram guided FNAC. And then once the FNAC gives you either coidy lymphoma, then always go for a core biopsy under ultrasonogram. And then we have the MRI and the CT. We'll just see which all we have to do. FNAC is widely recognized and established method of evaluating. Sensitivity is 85 to 90, but specificity is 96 to 100. It is a Millen system for reporting salivary gland pathology. This is the Millen system you can see. Then core biopsy, not routinely used. Invasive method. Why it is not routinely used is increased risk of facial nerve injury might be there. So it can be useful in classification of lymphomas and immunohistochemistry and for IHCs. Ultrasonogram is an ideal tool for early evaluation. It's a non-invasive, inexpensive, and can be performed to increase the sensitivity and no radiation exposure. So in a benign, but one thing is, I'll tell you later, and it tells you like where exactly is the tumor is situated, whether it's a superficial lobe, deep lobe, and all that features you can make out with the ultrasonogram. CT scan primarily as well as neck metastasis can be assessed, and bone invasion and destruction are better picked up. Assessment of both superficial and deep lobe. It is the best tool to rule out silolithiasis. MRI. After ultrasonogram, it is the MRI which comes for us in salivary gland tumors in parotid gland. It is a better soft tissue delineation, can differentiate the normal gland from the actual lesion, and so that you will know the extent of the lesion. Deep lobe involvement is better assessed. Ultrasonogram fails in deep lobe because of late I've seen in many of the cases where they said that superficial lobe is involved, we took, and then it came as deep lobe involvement. Deep involvement is better assessed. Perineural perivascular assessment, this is one of the very important feature. Facial nerve assessment and intracranial extension is better picked up. Preoperatively, how do we locate? Retromandibular vein you locate, and then the facial nerve will be lateral to it. The tumor is there, locate the retromandibular vein. This is all we can do with the contrast enhanced, and then we'll have to sit with the radiologist and tell them. Pathological finding in imaging. Mass is unilateral, shows a post-contrast enhancement as a high T2 signal, high signal intensity on T2, and does not invade the surrounding tissue planes. It is more likely a pleomorphic adenoma. So you have to do one high signal intensity on T2, it is pleomorphic adenoma. Whereas intermediate to low signal T2 signal mass with or without invasion of the surrounding tissue planes is more likely to be a malignant mass, such as adenocystic or mucoepidermoid carcinoma. So anything in the mucoepidermoid and the adenocystic, this are all done in, it's published in so many literatures. I have not put it. The intermediate to low T2 signal mass with or without invasion of the surrounding tissue planes, then you need to think of mucoepidermoid or adenoid. Parotid gland mass is bilateral. It is more likely to be a Warden's, especially if it does not enhance. So this is just you can see here, non-enhancing and same enhancement as the subcutaneous fat. So this is seen in case of lipoma.
Yes, sir.
Yeah. And then here you are seeing the, sorry. Yeah. High signal intensity on T2. This is pleomorphic adenoma. And then here you see intermediate to low, as well as here in the periphery, you can see high intensity. That's because maybe the inflammation, this is seen in mucoepidermoid or malignancies, any of that, adenocystic or mucoepidermoid. Then PET scanning, the PET CT scan usually does not have any unreliable uptake is there, but recurrence or of an operated case, it can be used. Not regularly we use it. Treatment, now let's start with the treatment. Surgical management. Does non-surgical management is there wait and watch policy for benign lesion. Patient is always given a surgical and wait and watch option. But always we have to tell, like if at all, because in pleomorphic adenoma, after 5 years, the chances of malignant transformation is there. It is around 5 to 6%. And if at all they wait for 8 to 10 years, the malignant transformation is around, I think 25 to 30%. So we need to tell them, and then we'll have to address that. Then radiotherapy and chemotherapy. Surgical, what are the surgeries we have in the parotid? We have superficial parotidectomy, and where I told you the arbitrary, the parotid gland is divided into superficial and the deep lobe. So entire superficial lobe, that is divided by the facial now, okay, and the retromandibular vein. So anything above the facial now, the full gland you remove, that is called as superficial parotidectomy. But now there is something called as adequate parotidectomy. See, whatever you do when you have a pleomorphic adenoma, for example, of the superficial lobe, okay, see, it is there in the superficial lobe, but because deep to it also, it's a deep lobe. We are not removing anything from the deep lobe. It is just the facial nerve is there, but we are not removing. So 3D-dimensional excision of the mass is not there on the undersurface, but still we do not have so much of recurrence. So then that concept of adequate parotidectomy came, wherein you excise the tumor with a good cuff of tissue surrounding, so that whatever the pseudopod it has, you remove it completely. You need not go for superficial. Like for example, if the tumor is there down, like near the tail of the parotid, you did not excise the entire superficial lobe. Rather than that, you identify the facial trunk, and then only the cervical branch you trace it, and then you remove the tumor there. So that is what is called as adequate parotidectomy. But it is not enucleation. Enucleation is where you don't identify the nerve, nothing. You just the tumor is there, go and then just take out the. You should not that. It is the adequate parotidectomy where the regular steps of parotidectomy is done. We identify the facial trunk, and depending upon where the mass is, then we trace those nerves, and then a good cuff of tissue along with the tumor we remove. and total conservation parotidectomy, radical parotidectomy, and neck dissection, depending on the type of pathology you are dealing with. What are the points to ponder whenever you have planned your surgery? So what do you think you need to go? So you should always write down incision of choice. Yes, I'll show it in the video. Elevation of the skin flaps. This is very important. Which level we need to elevate, only the skin or subplatysmal level in the neck, and then that is subsmash in the face. Then facial nerve monitoring, whether regularly we use, I don't use regularly. Only thing is in deep lobe parotid tumors or in recurrent cases, our neurosurgery people have, I'll use it. Otherwise, the regular superficial parotidectomy I don't use. And method of facial nerve identification, it's very important. See, we cannot go for facial nerve monitoring always. So method of facial nerve identification, what we identify will tell. Extent of parotidectomy depends on the pathology. Augmentation, once we remove the parotid defect, how do we augment it? Then indication and extent of the neck dissection. This comes only in cases of malignancy, and method of facial reanimation. I think I'll go for my video.
Yes, ma'am. Yes, ma'am. I see that many colleagues are here already. I see a lot of many senior surgeons also, like Dr. Mohan Jagre, Dr. Prakash Munkan, so many of them. Dr. Satish is there, Dr. Sanjay is there. So who all are performing head and neck surgery? Okay, parotid surgery. Please let us know. If you are already done several surgeries, type 1, if not 0. Okay, let us have a this thing poll here, friends. Yeah, let us be interactive. Yeah, if you're already performing parotid surgeries, yeah, type 1 in the chat box. Otherwise, 0. Let us have a this thing consensus. Yeah, yeah, the numbers are coming now. Yeah, you can send me direct message. Yeah, 1, 2, 3, 4. Yeah, you can start your video, map. Meanwhile,
one second, I'll just.
Yeah, you have to share that video file.
Yeah.
Yeah. Yes, ma'am. Yeah. Can we pause, ma'am, before we proceed?
Yeah.
See, what incision you choose routinely? Is there any change in patient to patient, or you use all patients same incision? How do you go, ma'am?
Yeah. Actually, I use the same modified blade, but here I'll take over the tragal cartilage like this.
Okay. Yeah.
And then ear lobule, hug the ear lobule, go over the mastoid process, and then I come down. In some patients, I go for hairline incision post-auricular. I'll show you this in the video. I'll just put that and.
Okay. You can play, no problem. Yeah.
So this was the incision which I used to do before.
Okay.
And here, actually, this is, it used to be sharp. You remember when we started our surgery 25 years back, not now, 29. Okay. It used to come, hug the lobule, go back, and then we used to go like this.
Yes, ma'am.
Okay.
Yeah.
But now I've changed. This is the first incision. This is the incision which I use.
Okay. So it will go over the summit of the tragus.
Yeah, summit of the tragus. Then come here. Then come here. Smooth the curve over the mastoid. Then come here. And then it joins the upper skin crease. Okay.
Yeah, upper skin.
This is the other incision where the hairline incision. And then some cases before I used to go on the posterior aspect of the tragus, then come. But what I found out with that is when I'm lifting from the posterior aspect, coming to the summit of the tragus, then coming anteriorly, I used to sometimes cut the tragal cartilage. And then when I used to suture back, when you reflect the skin and suture it back, then that tip of ear, that summit, it used to be blunting edge I used to get.
That's right. Sometimes also the punctures.
Yeah.
I tried in 1 or 2 cases. I made small punctures in the skin, which
Uh-huh.
are quite suturing. I stopped doing that.
So I started doing this
Yeah. Okay.
summit like on the upper edge of the tragus,
Okay.
and then come here. Then
So it
this
doesn't
is the
leave any
incision.
scar there, isn't it? Visible scar won't be there. It's
Yeah.
yeah.
Correct.
Okay. Okay. And
This was a
the
tumor.
incision which you go behind here over the mastoid, you you had any incidences of skin necrosis or flap necrosis there?
No.
Okay.
Actually,
Okay,
even
this is
before when we used to have, before we all used to take the sharp here or the, if at all you remember, like this, it used to come.
Okay.
Then also we never had, because I'm a very slow surgeon. I take my own time to suture it.
Yeah.
Maybe that is the reason. And then this is the mastoid angle. I mean, sorry, mandible angle. So always I mark.
So you're marked. Yeah. No, this is a very good. This thing you have showed. I mean, this is a very good, very important take-home message. Otherwise, we have to keep on palpating where is the angle.
Yeah.
So marking that angle with your marker pen is, I think that's very good, or very important strategy. And one of the questions is, do you use any pre-op photographs before operating parotid tumors, just to show that there was no facial paralysis?
Yeah, this is the patient.
Yeah. You routinely do photography?
Yeah, we do video consent also.
Okay. Very important.
Video consent.
This is a very important take-home message, friends. If you have facility, do video consent. Okay, that's very important.
And video consent, even if you don't have the facility, you can take your mobile and then do the video consent.
Okay.
And then written consent also. We have to take. It's real consent we should take, not the informed consent. Then full. We tell everything, what all the problems the patient can have, whether it is temporary facial paresis or permanent, and then now Frey syndrome and first bite syndrome. If it is a huge tumor, parapharyngeal space for that, but not for the just superficial parotidectomy.
Okay, not for the superficial parotidectomy. Yeah. So you also don't routinely use facial nerve monitor for these cases?
No.
So now I see that many surgeons, they express that they're operating parotid tumors. So who all are using this thing, facial nerve monitor in these cases? So please, if you're using it, type 1, if not 0. Okay. Come on, friends, let us know what you're doing. Okay, ma'am, run the video, ma'am.
Okay.
Yeah.
Maybe in the corporate, they use for every patient, I think. We are not, we cannot afford to use, that's all.
Yes, it adds to a lot of cost, It makes sense if you are a good anatomist, you're able to identify the nerve, preserve it.
Then I always infiltrate.
Yeah.
So my infiltration will be 1% adrenaline with normal saline. And then we paint the area.
Okay. So you use that ready mixture. That is the 2% zolocane with 1 in 2 lakh solution. So you make it 1%.
Yes.
Okay.
And I always mark these areas like this.
I mean,
so
this
that
is a good strategy.
Suture at the end, I should know.
Yeah. I think this is a very good strategy to get a proper alignment. Yeah. Okay.
So in important areas, you should mark all this. In lip, when we do all those lip, oral caries now. So there, ear.
Yeah. Okay. Okay.
And usually we have to use the knife and the scissors.
Okay.
But when you start your surgery, better to use for the elevation of the skin flap, knife or the scissor, which you are used to it. But once you are experienced, then it's okay.
Yeah, you can use the bipolar.
Yeah.
Okay.
Then we slowly elevate the skin.
Okay. So a combination of a blunt and sharp dissection is used here. Yeah.
Yes. So you get into the platysma, subplatysmal, and then this is the subsmash.
Yeah, yeah. Uh, Now there's some surgeons they mention a concept called a parotid flap, parotid facial flap. Because somebody asked me, do you elevate parotid facial flap? But for me, I found it very difficult to identify that fascia independently
No,
and
I
rise that
don't.
flap.
Yeah. Always
Uh,
I go in the neck, then subplatysma, that will be converted
okay,
to the subsmass.
okay, okay. Yeah. So the same subplatysmal flap you extend upwards.
Yeah.
Yeah, yeah. And anteriorly, how far we have to go, ma'am? I mean, that is one thing because there will be buccal fat of fat and this thing.
I
Sometimes
think
difficult to demarcate where the
correct,
gland
correct. I
ends and
have
the
shown
fat.
the
Yeah.
mesenteric muscle there. I'll just,
Okay. Okay. So your anterior limit is the
yeah,
mesenteric
anterior
muscle.
margin of the
Yeah.
parotid, and
Yes.
then you will see the masseter muscle. There you should cut short because all the facial nerve branches exit from the anterior margin of the masseter, and then it goes to the anterior margin of the parotid gland, and then they enter the masseter. So once you get onto the masseter, you should stop your dissection.
Dissection. Okay.
Only
That's where the
anterior
gland
margin.
ends. Yeah.
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 Where
Very.
the gland ends.
That's a very good take-home message again. Anterior how far extent we should go. Yes, ma'am. Great. Yeah.
And then once we elevate that, then where's my okay?
Now we have a lot of time. You can go slow. You don't have to hurry up. Yeah.
Okay.
Unless you have
Now,
some dinner program
no.
outside
See,
somewhere.
now the parotid fascia with the parotid gland is
Okay.
elevated from the anterior border of the sternocleidomastoid muscle.
Okay, that's in the neck. Yeah. Okay.
Yeah.
Okay. Yeah, you're dissecting the anterior border of the sternocleidomastoid from the parotid. Yeah.
And either I use the loop once in a way. I use the microscope, and I need to. This was one need to record. I did. Otherwise, I always use the loop.
Yeah, yeah. I think it's very important to use loop. Yeah.
Always.
Yeah.
And then position of the patient, supine with not too much of extension. Okay. Okay. Just the edge should, it should be put back. That's all. Yeah. Yeah. Okay. That is very important. And neck turn to the opposite side. Yeah. And sorry, I forgot to tell that position. Yeah, position. I think we should have discussed that to start with. We can pause a little bit and we can explain the position and go ahead, ma'am. Yeah. So what position you keep usually in these patients? Supine position, then a small shoulder back under the shoulder blade, and then head is rested onto the head ring. Okay. Okay. It's not too much of extension. There is no need to give too much of extension unless until you're doing neck dissection. Okay. It should just, the edge should be back. That's all. Okay. Okay. Yeah. Any other position you use? No, no, ma'am. Perfectly all right. I think we all use the same positioning. Yeah. Turn to the opposite side. Yeah. 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 Okay. Only if at all we have any difficulty, like when you proceed with your dissection, you're not able to find out. Maybe the table tilt to your side little bit might help you to identify the facial turn. Otherwise, it's the same position throughout the surgery. Okay. Okay. Yeah. Yeah. Dr. Ekambar Reddy, who's from UK, he wants to make a comment. Yes, sir. You can unmute yourself. Yeah.
No, that's okay, Dr. Prahlad. Let her finish completely. In the end, we can discuss. It's going on very well. So,
yeah. Okay. Thank you very much.
Thank you, Doctor.
Yeah.
And then welcome, from the anterior border of the sternocleidomastoid, you can see we have dissected the parotid, posterior border of the parotid is off from. That is to identify the digastric muscle. See there now. What is our aim is once we exposed everything, now we need to get onto the facial now. So to get onto the facial now, we need to separate our parotid gland from the tragus and the cartilaginous meatus, and from the anterior border of the sternocleidomastoid, and the tail of the parotid should be lifted off the digastric. So these
Yes.
are the 3 areas where our dissection should be there.
Okay.
And so that we can see the facial now.
Okay.
So
Yeah, I see that many junior colleagues, ma'am. So
yeah.
There may be situations where your standard technique may not show the facial now show up. I mean, any other facial pointers you use?
Yeah, these 3 points, if at all we are not seeing, then we need to go for the marginal mandibular. Now you identify retrograde dissection.
Yeah.
But usually it's done only in very, huge tumor you have. You cannot get into that. But I don't think that will be regular supervision of parotidectomy.
Okay.
This is the superior border. Sorry, I fast forwarded. I mean, it's recorded in a fast forwarded mode. So this is the superior border of the digastric muscle. You can see the superior border where it is attached to the digastric groove. And then you can see the vessel. This is the vessel. You can see underneath the vessel, there's a white structure.
Yeah.
So that is a branch of the posterior auricular artery.
Okay.
Now you can see this, you can see the white structure.
Yeah.
This is the nerve.
Okay.
See, as long as your dissection is above the superior border of the digastric belly, you will not come across your facial nerve. So you can be sure about it. So,
okay.
And then you can see the facial nerve.
Can we pause, ma'am?
Yeah.
Just to go through this thing, different landmarks here. Okay. Yeah. So if tragal pointer is to be used, where exactly you would look for? If you want to look for the mastoid suture, where you will look for, and the digastric. How do we identify the digastric pointer here? Yeah. You can pause for a while. And
see, this is the once we separate the parotid from the anterior border of the sternocleidomastoid, that is posteriorly, and the inferior part of the parotid, when you separate, then you get onto the digastric muscle.
Yes, identify the digastric.
Identify the digastric, identify the superior border of the digastric, and then you dissect slowly till the where it gets attached to the mastoid process.
To the,
that is the first thing we do. And then here, the parotid, you have to separate it from the tragal cartilage. And when you are separating from the cartilaginous meatus, you can see this cartilage, the pointer. The lower end of the tragals is that it's sort of pointing there. If at all you have any doubt, I usually, when I have doubt, I put the mosquito in the excentric canal, and then where just below the tragal pointer, your mosquito will be pointing. You can see that.
Yeah, that's a good trick. I think that's an excellent trick to get it to make the tragal pointer more prominent.
Yeah. And then you have above, below, behind this or medial to this, then styloid process also will be seen.
Yes. We can also palpate it and then see it. Yes, ma'am. Yeah. Okay. Those are very important pointers that junior colleagues have to remember. And try to identify. And sometimes the tumor can be very bulky. We really have to lift the tumor away, right?
Yeah. When you have a bulk, huge tumor here, then it's very difficult. That is there. See, this is the styloid process here, tragal pointer. It's very fast forwarded.
It's okay.
It's recorded in a high speed.
No problem. So, that's why I asked you to pause and show the landmarks. But it's very clear for all junior colleagues. But you're using something there in between, I saw
the distance. Once I identify the tragal pointer here, and then the digastric, then 1 centimeter I cut the scale, and then I'll show. 1 centimeter
that's very
inferior.
Good. That's a very good strategy. We try to only take an approximate measurement, but you have a scale for that. I mean, for accuracy, I think that is a very important take-home message or a tip out of this presentation. I think, yeah.
So from the tragal pointer, 1 centimeter below and medial to it, and then you just mark it, and then on the superior surface of the diagnostic, then you take all these tissues off.
Okay. Okay.
Then once you do that, then you will be on your facial now.
Yeah. Okay, ma'am. You can go ahead. Yeah. Now it is seen the trunk of the facial, which is quite thick actually. Yeah.
Yes.
So you're reconfirming it with the scale.
Yes, that's the
very nice.
styloid process actually.
Very good demonstration, ma'am. Fantastic. Yeah.
And this is a tragal pointer.
Yeah.
Now, once we identify, see the next work is you make a tunnel, supraepidural, like the facial branches will be going like that. Above the trunk, then you make the tunnel. Okay, that is between the superficial lobe and the facial now. You make the tunnel and then you cauterize. Make the tunnel, lift the superficial lobe, and then with the bipolar cautery or harmonic scalpel, whatever, depending on the facilities or whatever it is. Then you put, well, only thing is whenever you're using bipolar cautery, see that your assistant will put the water on it. That's all. And then so that it will not stick. One. And then efficiency will be more. And then you cauterize it and then you cut it with the scissor.
It also minimizes the thermal injury, if any.
Correct.
Yeah, fantastic, man. Yeah. Go ahead.
Yes, you can see that now.
Yes. Yeah.
You can see the branch here.
Yeah.
Marginal mandibular.
Many times we have this temporary marginal mandibular paralysis, and mainly because of the retraction of this flap.
Yes.
I think, I mean, I have had this experience, this problem in a couple of cases. Yeah. Which recovered anyway in a few days. Yeah. Now we see more branches here.
And as I told you in my PPT thing,
yes, ma'am.
The facial now, it's not always uniform. Like, last case I've done this. This time also I'll see the same architecture of the facial now. No, each patient is different. So have your own time and then identify each branch properly. And especially all the branches, they're all like, as you go peripherally, they are very tiny. And then they have the ramifications. So always inter-ramifications, inter-branch ramifications, you preserve them.
Yeah, very important. Yes. So there, the message is there may be a lot of numerous anatomical variations. Be aware of it and follow. Yeah, very important. Yeah.
And the temporal, as it goes, then okay, you can see.
Yeah.
Each branch, small branches. There is everything you preserve.
Yeah.
That's
you need a lot of patience, slow and steady.
Yeah. That's possible only when you have magnification, either the loop.
Yes. I use the Kim's headlight with 2.5 magnification.
Yeah. Actually, this patient ultrasound that was showing only tumor in the superficial lobe.
Yeah.
FNAC came as pleomorphic adenoma. You see here, in between the two ramifications, that is the buccal branch and zygomatic, the tumor was going to the deep lobe.
Okay.
I'll show you here. Cervical, marginal mandibular. That is just to show.
Okay.
And which way you deliver your gland is immaterial, either in the sense like go full and then like above and below, and then go to the anteriorly and then you take it out, or below you separate and then go around the anterior border and then go above. But whatever way you do, it is only the preservation of the nerves. That is important. That's all.
Yeah. Yeah, that's a universal principle in superficial parotid surgery. Yeah.
And one thing is, somehow I escaped, I don't know when, this great auricular now, maybe I'll show you afterwards in the first.
Okay.
The anterior branch was usually, because it goes to the gland, you need to sacrifice, but the posterior branch you need to reserve.
Okay.
If at all it's not entering into the gland, if at all it's not going through the gland. See, now we separated all, we came to the anterior. Then I found out that in between these two branches, the tumor was going into it, into the deep lobe.
Deep lobe, yeah. That's a catch-22 situation, ma'am. So how should we go about it? About the deep lobe?
Then I stopped. I went outside. I told the patient mother, because she's a young girl. I told her, see, and this is it. I cannot leave because I cannot cut through here and leave the deep part. Then she'll have a recurrence, and that will be more disastrous.
More difficult to perform surgery.
So I told her, I'll take utmost care. Because the branches were already there. Only in between the two branches, it was going down. So I told her, this is a situation. She might have some paresis post-operatively. If you're agreeing, I'll go ahead. If you're not agreeing, I'll just come out with this. So they said, they thought, then they said, no, you can go ahead. So you can see the tumor which was going down here.
Yeah.
So this is the buccal branch which separated totally. This. And another patient I to tell. Actually, there was no tumor in the superficial lobe at all. See, sometimes most of the cases, if at all it's a small and pleomorphic adenoma on FNAC, we don't do MRI. Okay, the tumor is there in the superficial lobe. But that patient had nothing in the superficial lobe. I just reflected the superficial lobe, and then the tumor was in the deep lobe. Then we did, and then came out.
Yeah, that's a tricky situation.
Only thing is, but I don't know whether the patient consent will not be there at that time. But whether we need to add in the future, like if at all the MRI is not done, only ultrasound on table, maybe you might be having like this. I don't know.
Yeah, sometimes the MRI, the ultrasound may miss the deep lobe.
Yes,
mainly because of the location, the mandible comes in the way. That's true. And MRI is expensive for our patients.
Now the deep lobe came. We went out, took their permission, slowly separated.
Yeah. Yeah, you're still able to dissect between the nerves. Yeah.
Yes, yes. See, this was a one branch. This was one branch. In between the branch, I could go deep.
Yeah.
And the muscles, I could take off from the muscles. You can see the muscles also one side dissected.
Yeah.
Only thing is our dissection becomes very slow. That's all.
Yeah, I think it deserves the time, I think.
Yeah.
Definitely. When we have such a lesion, I think it deserves all our time. Yeah.
That's a muscle. Slowly dissecting of the deep lobe of the muscle. Yeah. Yeah, you can see the tumor has come out of the bed.
Yeah.
You can see the buccal branch.
Yeah, the patient is very lucky to have as a surgeon, a surgeon. Yeah.
Yeah. Okay.
Yeah.
This is the bed.
Perfect. Yeah.
So all the branches you can see.
Mm-hmm.
There are so many branches. See, not only 5.
Yeah.
There are so many. See, 1, 2, 3, 4, upper buccal, lower buccal, and ear also.
Yeah.
That's again upper border of the stomach, digastric, just to show. Now, after this, the next thing is sternocleidomastoid muscle. I always close the area with the sternocleidomastoid muscle.
Okay.
Always. Last, I think, more than 15 years. So,
to protect the nerve?
No, to prevent the phrase syndrome, as well as, when you remove the superficial lobe, that what do you call the spay, the deformity will be there, or whatever it is, the what do you call the space occupied by the superficial lobe.
Yeah. There may be a depression.
So the hollowness will be there.
Yeah.
You can compare always to the opposite side. The hollowness is more because with that the healing also happens. The skin goes into the deep lobe.
Yes.
And the deformity is there, unequal
area.
Yes. So to put some tissue for that, one is a sternocleidomastoid muscle flap you can use, as well as it prevents the what do you call? It prevents our phrase syndrome also. In some cases, I've used even the fat also, abdominal fat, but temporoparietal flap I've not used. My experience with that. And even allogenic dermal fat, that also I've not used.
Yeah.
Usually, because we are in the same area, we can just rotate the
sternocleidomastoid. It makes sense, ma'am. It's easy. Yeah. I think ENT surgeons are blessed with a lot of graft material around this area.
Yes. See.
Oh, very nice. Fantastic. And this is a good take-home message for me. That we don't get many parotids here once in a while, but I think it's a nice thing to do. Yeah.
And it protects your facial nerve also. I mean, in the sense when you are putting a drain, okay, it protects. See the defect which was in the deep lobe here.
Yeah. You fix it to the masseter muscle there?
Yeah, anteriorly, and then above soft tissue, whatever you get. Above and below. Below to the platysma.
But is you do it in all cases?
Yeah.
Okay.
All.
Because whenever there's small tumors, this flap itself may become little bulky.
No, it depends. I'll take a small flap. I don't take
okay. You're taking a small flat thin this thing.
Because that prevents a phrase syndrome also.
Yeah, that's a good strategy, certainly.
See now.
Fantastic, man. Very nice.
I don't know now. I mean, everyone should give their opinion now, because so many seniors are there. And now I'll suture this.
I welcome Dr. Jan Panikar sir is there from Trivandrum.
Okay.
Yeah, senior man is here.
So what all marked areas I've done, no?
Yeah.
So I'll suture it back.
Yeah, gives a good alignment. This thing.
And always use non-tooth, smooth adsense for the skin to hold. Because don't traumatize the skin, because facial skin is very delicate. So drain I'll put. I'll put the suction drain only, but the negative pressure will be very less.
Okay. Any specific reason for that, ma'am?
I don't want to put too much of pressure, but even the sternomastoid muscle like protects the facial now. Because if at all you put too much of pressure, then the facial now, if at all it is, get exposed, it might it can have temporary paresis also. That's why I don't use too much of pressure.
Okay.
So till year I do. From year to year we put the
subcuticular. Okay.
Yeah, this is from year to year subcuticular.
Perfect, ma'am. Yeah.
So this is our.
Any post-op pictures, ma'am?
Yeah, I'll show you.
Yeah.
I'll stop sharing this.
Yeah. You can go to the PowerPoint presentation. Yeah. Picture. Yeah.
Okay. And the incision of choice, I've told elevation of the skin flaps, I've told methods of patient identification, patient monitoring, extent of parotidectomy, augmentation I've showed, indication and extent of neck dissection I'll show later. That is
fantastic. All the critical points which are required, which we need to remember, which we need to execute, are demonstrated very well.
Yeah. So this is the SMAS subplatysmal and SMAS, how we elevate. Or the fascia, this is the parotid fascia you can see. And this are all to prevent the phrase syndrome. This is the sternomastoid muscle flap. And this is the fat.
But do we see phrase syndrome in all cases? So suppose in case we don't cover it like that.
In my cases, 2% incidence is there.
2% incidence.
Even if I covered also.
Oh, okay.
Yeah, but not very troublesome. Like she says, very little area, maybe it just reduces the area of the thing. Small area, whenever she eats, she gets little, not too much of flushing or sweating.
1 or 2 drops. It just dribbles. I have had one patient. Incidentally, that patient is from Mysore, operated in Bangalore when I was at DGS Global Hospital. That was chronic saladitis patient.
Okay.
suffering a lot, and that patient developed this thing. She didn't agree for any revision surgery or do something, but really she trust me a lot. To be honest,
Yeah.
It happens. What to do? Yeah.
And this is another patient I told you, no?
Yeah,
See,
yeah.
This is the facial nerve branch. Underneath the tumor is a deep lobe tumor, which ultrasound showed a superficial lobe. I opened up, and then we separated slowly. We removed the deep lobe, and no facial paresis. I'll show the photos.
Yes.
I think these are all. This is the same.
Yeah.
I'll just small video. Total conservative parotidectomy.
Okay.
Same. Same steps. Only thing is after removing the superficial lobe, separate the facial nerve trunk.
Okay.
Sorry. This in between. This is how the bed looks. Surgical placed.
Yeah.
Because my talk was only for superficial, just
we thought we'll keep this at this stage for the only this thing,
These are all radical which we have done.
Yeah. We have a lot of junior colleagues from different part of the world who look for basic things. So we thought we'll keep it for this only. Yeah.
So facial nerve injury, whenever we come across primary closure with 2-0 nylon, repaired with cable grafting. This usually happens in cases of malignancies when we do. I've done, I'll show the child photo. He was an 11-year-old child. He had a cervical branch full. That whole trunk was involved with the tumor.
Okay.
But no paresis was there. It was just adherent on the epineurium. Then we took and sent for frozen. It came positive. Then the negativity of the margins was established. And then I did the great auricular nerve grafting. Child is now 16 years or 18 years now. She's fine.
Okay.
I'll show the photo also. Great auricular nerve deficit, sensory deficit may be there. Sometimes whatever it is, if the tumor is going, or you might, majority, I don't say that in all the cases I can, preserve the great auricular now. Okay.
Yes, ma'am. That Sanjeev Mohanty, Professor Sanjeev Mohanty is there from Chennai. He has a comment, a query to make. Yes, sir. You can unmute yourself.
Hi, Prahlad. Wonderful. I was following each step of it of ma'am.
Hello, sir.
Hi, ma'am. It's been long that we haven't met in person, but we've been. And parotid also is one of my love that I told you last time during the skull-based thing, Prahlad.
Yes, sir. Yes, sir. You're right.
So just take on the incision part, we also use the Blair or the modified Blair.
Yeah.
But off late means the last 10 years.
Yeah.
I've kind of modified the, the facelift incision in a way that it's very, I name it as aesthetic parotidectomy, because you take the, from the incisura, you take the incision. Go little posterior to the summit of the trachea. So you go inside. And then as ma'am took it around the lobule, go in the retroauricular groove, not with a cautery, so that the so-called the branches of the post-auricular artery branches are still served, they're conserved. And then when you, as a very gentle curvature, go along the hairline. On the posterior part, and you dip down, you get a very good exposure. You have the Maestro in place. And in this case, if you take a skin hook and retract the skin anteriorly from the tracheal skin, tracheal cartilage is covered by the skin. You hug the tracheal cartilage, the entire cartilaginous portion of the EAC, you go straight down. Believe me, this tracheal pointers and all that, which is written in all the books of Hayes Martin, all of that. it is little theoretical, because if you really go see the tympanic plate and between the mastoid and the tympanomastoid suture, as you just mentioned briefly, that is the most constant thing anatomy that I've seen in, I mean, probably more than 200, 300 parotids I've done over the last 20 years. And I've seen that is the only consistent landmark that anatomically that you can have. So the moment you get the mastoid in place with this flap, until you have the tympanic plate, you cannot miss the trunk. So first thing I do is identify the trunk before doing any other dissection. And then, I mean, there's just a different version. Everybody knows how to do it. It's just a way to skin
certainly, we need a different perspective how each surgeon performs. So that way, when we are flexible, when we know multiple ways of doing the same thing, when we have a challenging situation, we can, with these are the pointers which are very handy. So thank you very much for that.
And one last point, in every case of parotid, I do what ma'am does. That is, take a cuff of sternomastoid to rotate and put it there. That is only because three functions, not for the Frey syndrome. One, off late, if it is, you're very sure I don't put a drain because of that. It obliterates the dead space completely.
Yeah, very important.
Secondly, the Frey syndrome, as she said, and it also gives a very good aesthetic to the whole thing.
Yes.
And cover it with a very, observable sutures with a, in-bent knotting. And the patient goes home after 2 days. You don't have to do anything. I mean, this is over time that I've developed. That's just wanted to share.
Perfect. I mean, it makes sense, particularly for me, this is a very good take-home message, it's fantastic. Thank you very much for sharing, sir. Thank you for joining our meeting today.
And always for teaching.
Yes, sir. Yes.
Thank you, Bharathi, sir.
Yes,
nice tips you gave us.
No, we will keep meeting. We just missed out this time because of COVID. Couldn't go to Ranchi. Otherwise, probably next time around we'll have a good session together. Thank you, man.
Thank you, sir.
We have okay, ma'am, you can continue, then we can go for queries, questions.
Greater auricular nerves. I mean, all this I didn't show in the video. I mean, because it was only for superficial parotidectomy.
Yes.
Because in that case, you are never supposed to injure the facial nerve injury. If at all, it is only superficial parotidectomy. But for other reasons, if you are doing, it's a malignancy, but at that time you are not doing only to superficial, you're doing total parotidectomy. So that time all this can happen.
Always do a primary closure, primary suturing.
Yes.
Very important point.
But so if at all you have it, that's what I told you. This the girl. You can see this girl.
Yes.
Now she has only this much of deformity. She had the.
And what I feel is many a times it's mainly because of the retraction of that flap neuropraxia.
No, she had cervical trunk involvement.
Okay.
That was a mucoepidermoid carcinoma, intermediate grade.
Okay.
So I had to do MRND and then remove the send the facial nerve on table for the frozen. It came positive. The negativity of the margins I established, and then we did the great auricular nerve grafting.
Okay. Interesting.
And wound infection, because we cover with good antibiotics, I don't think we see wound infection. Hematoma, seroma. I usually keep that Penrose drain or corrugated drain or the suction drain with the less negative pressure for 1 day, 24 to 36 hours. Salivarily, yes, this can happen if at all, when you are dissecting off the parotid from the sternocleidomastoid, you don't take you enter in through the tissue of the parotid, you leave some tissue there, then you can have the salivary leak. That all is very, temporary. Frey syndrome, I think we covered already. First bite syndrome, only with superficial parotidectomy we don't have. Yes, I have with the parapharyngeal space tumors, whenever we have excised, we have. Then flap necrosis, I don't think we have. Except in case where we have, brought the reconstruction. So you have the huge skin defect, and then we have done the reconstruction. That time, in some cases, we had the flap necrosis.
Okay.
Okay, this is a child with mucopelma, all this. This is 85 years old lady. So
Yeah,
this is a total parotidectomy. This is a normal parotidectomy.
Okay. Okay. Yeah.
And,
This thing, one query: do you counsel the patient about the possibility of facial nerve palsy, paralysis, subparesis to all patients?
yes.
Do you speak to them?
Yes, yes, all.
Yeah. Okay. Yeah, I think that's a very important this thing. I mean, you always tell patients that that's one possibility, so that they're prepared if something happens. So they're always prepared with that. Yeah, that's a better this thing, I think. Next query is from Dr. Just make Dr. Ekambar Reddy. You can now unmute yourself, and he wanted to make a comment.
Yeah, thank you, Prahlada. Thank you very much, madam. That was a very good presentation. I think for all the juniors, it's so useful. And what you highlighted, the wide exposure rather than digging in a deep hole. Some people do just dig in a deep hole trying to identify the facial nerve trunk. So going from above and below, that's a very good point you mentioned. And the greater auricular nerve branches, to try to preserve, always we try to preserve. That's another good point. Anterior branch, many times we can't preserve, but the lobular and the posterior branch, we should always try to preserve, if possible. That makes a big difference for the patients, the amount of numbness. I know that I wouldn't call it as a complication. It's more like a sequelae. You can't avoid some of it. And what I tend to do is, if we cut the trunk at all, I've seen few neuromas occurring and causing pain. So I tend to bury the trunk into the sternocleidomastoid muscle, if that's seen. And the other thing I wanted to mention was, the marginal mandibular branch. I think why we see that temporary weakness, quite a few patients we see. I think it's because there's very less connecting branches or the anastomosis with other branches. That's the reason.
I that could be one.
And this technique of putting the sternocleidomastoid rotation will prevent the defect occurring and all that. That's a very, very good point.
Really, it's a fantastic take-home message.
So what I tend to do more than which madam hasn't mentioned is about extracapsular dissection technique for these benign parotid lumps. I think last 10 years I do majority of them for benign tumors, extracapsular dissection. So when we say extracapsular dissection, it's not enucleation. So you're not going to identify the trunk. So the trunk is left bare, but the thing is you need a nerve monitor. Without nerve monitor, it's not safe to do it. You need a continuous nerve monitor to do. So this is all from, if you think when we do superficial parotidectomy, just imagine we try to dissect so much everywhere, but when the tumor is close to the facial nerve branch, we are very close, literally hugging the tumor. So there's no margins at all. So that was the basic theory, and it started from long time ago. Manchester, Nicholson, and they used to do it, and they have big evidence showing there's no difference in recurrence between superficial parotidectomy and extracapsular dissections. So, and then McGurk, I don't know whether you all follow McGurk, is the guy. He's written books and a lot of papers from London. And then Christie's Hospital in Manchester. So they have nearly 30 years follow-up with extracapsular dissection. So if somebody can do that technique, it is much less morbidity compared to superficial. And if you want to start, you should start with the tail of parotid lesions, especially if you think tail, what are the branches you're going to come across? Marginal will be the main one, cervical. Most of us won't even look for that branch. So what you tend to do is just simple elevate the flap so that you have 1 centimeter anterior to the tumor. And so the incision you can modify accordingly. And you make cruciate incision on the parotid fascia. So lift all the flaps up. And I use a loop, obviously. I like to use a loop. And if it's not there, microscope can be used. And then you dissect around the capsule, just few millimeters around the capsule, and you don't cut any tissue until it's so thin enough that you see the blades of the knife. And then you keep dissecting around, and then you can easily remove. So whatever pseudopodia are there, everything, you're all around dissecting it. So the advantages with that technique is, so literally eliminates Frey syndrome. Cosmetic defect will be less. I don't use any drains. People go home same day. So all these advantages, a lot of advantages are there. The only probably additional disadvantage is the silocele formation is a bit higher than normal parotidectomy. So I just put a pressure bandage on and send them home with a head bandage on. So that's the point I wanted to make. That's all.
Okay.
And when I see some, go
ahead. Yeah.
No, the other point what Madam told about adequate parotidectomy, like when I see deep lobe tumors, so you identify the trunk and lift the superficial lobe off. I don't excise the superficial lobe, then remove the deep lobe tumor, then put the superficial lobe back. So then you don't have the defect, the Freer syndrome and all that. So that's the other point I wanted to make.
Okay. That is only when isolated deep lobe tumor.
Yeah, isolated deep lobe tumor.
It doesn't make sense to excise the superficial lobe. Yes. I mean, those are good pointers you've given. I would like to see that technique sometime, Dr.
I'm happy to present if you want.
Sure, definitely.
I presented in a Karnataka conference a long time ago in Bagalkot. I presented. So,
you're going to be one of our Maestro during future events. We had you during our last Otology Ninja program. Look forward to have you again in the future also. Thank you very much, Ikamba. Hope. And then Dr. Sanjay Helale, you can unmute yourself, sir.
Hello, sir.
Yeah.
It was a very excellent demonstration and a lot of pearls to be taken home. But there is one query: when you reconstruct it with sternocleidomastoid, in case of malignancies, how do you monitor with imaging? Because the monitoring for the recurrences.
No, for malignancy, I don't put sternocleidomastoid, the flap. That's why we put the fat there.
Sir, only fat. So the imaging becomes easy with the fat separation.
Yes.
Yeah, I think.
And the second thing is regarding infiltration, ma'am. So I have 3 parotids next week, so I have a lot of things to learn from you. But I do saline adrenaline infiltration instead of xylocaine for 2 reasons. Only saline adrenaline 1 in 1 lakh. And I keep infiltrating intermittently. So you get a very nice bloodless field during dissection. And saline adrenaline doesn't interfere with the facial nerve monitor. Instead of a regular xylocaine with adrenaline.
Interesting those things. Tip. Yeah. Thank you, sir.
Thank you so much.
Yeah. Dr. Vivek Soman is asking these landmarks, whatever we use, what happens to them if a tumor is big and it pushes around? We still be able to get to the landmarks?
See, as far as possible, we'll be. But I mean, if at all we are not, then we first identify the marginal mandibular and then we go retrograde pattern. Because unless until it is infiltrating lesion, where the tumor is very big, and in that case, already the patient would have had the facial palsy, if at all it is plastered lesion. Otherwise, the tumor, even if it is big also, if at all you go slowly, you can separate the tumor if it is not adherent to the sternocleidomastoid. You can lift the tumor, then you can separate. Only thing is from the cartilaginous meatus and see. If at all you are not, then you use a retrograde pattern, go slowly, and then you identify the nerve. And that time, the nerve monitoring is important. You need to have.
Yeah. I think that's fair enough. That's a wise thing to do. Thank you, ma'am. Okay, I hope that answers Dr. Vivek. And we have Dr. Musa Kirfi from Nigeria. He says the consent part. Do you take both, consent for both superficial as well as deep lobe? Okay, of course, if the MRI is there, well and good. We can make an informed decision and we can obtain informed consent. In an absence of MRI, where you just have a ultrasonography which doesn't provide complete detail. So do you ask for deep lobe consent also?
That's better. That's what I've learned now.
Yeah. I think that's always better, better to be safer than sorry. Yeah, that's the right thing to say.
I'll show one more. If at all the time is there, I'll show one more deep lobe tumor. Just 1 minute.
Yes, of course. Certainly, ma'am. Certainly. You can go ahead and share. I'll stop sharing that. And also, if possible, I want you to show that flap again. Dr. Devi Durgadas, he wants to see that, sternocleidomastoid flap, how it was elevated, raised, and harvested and covered.
Yeah, I'll show.
Yeah.
You can see this deep lobe.
Yeah. We can see that deep lobe.
Yeah. So this is a deep lobe parotid tumor. This is a transcervical transparotid. What sir told now, no? Dr. Reddy told. So this is sternocleidomastoid muscle, which is retracted anteriorly and medially. The entire superficial lobe will be separated and it will be reflected. You can see the superficial lobe. This is a great auricular now.
Your video not visible, ma'am.
Not visible?
No.
Okay, sorry. Then I'll stop and I'll play first and then.
Yeah. This is such an interesting topic that I find among the attendees, there are from senior people to the PG level people. Many of them I know by name because of they attended the conference. So there is a great interest on parotid for the ENTs now.
Now you can see?
Yes, it is visible now. Yeah, please.
So transcervical transparotid approach. So you separate totally. This is submandibular, which is retracted anteriorly and medially. This is only deep lobe tumor, parapharyngeal space tumor. The entire superficial lobe will be separated. This is the greater auricular now.
Yeah.
See, this is the facial trunk. Once you identify the facial trunk, this is the tumor in the parapharyngeal space. You use the scope, visualize the tumor. See under surface, any vascular, any major vessel is there. Then alternating blunt dissection. You slowly deliver the gland off. It's a big tumor, you can see.
Yeah.
Now you suture the flap back. For this, we keep the drain. This is another deep lobe. This also, the patient ultrasound was not showing any tumor. I mean, it was showing in the superficial lobe, but on table, but any of the nerve monitor was used in this case. You can see the greater auricular now, deep lobe, tumor stretching the nerve, cervical branch, marginal mandibular, cervical. Slowly it was delivered. This is the bed of the tumor. I think this is okay. I think I finished.
Yes, ma'am. Can you go back to that original video? Dr. Devi Dugadas, he wants to see that how the sternocleidomastoid flap was raised. Yeah.
Yeah.
Yeah. Okay.
First, we separate the sternocleidomastoid from the skin.
Yeah. Yeah.
Okay. And then with a retractor, you coagulate and then cut. How much you want, you can take. I mean, the bulk.
Yes. Yes.
Yeah. You hold with the Babcock. Go to the tip of the mastoid process so that it should be mobile, and you have to put back.
Yeah.
So that you can rotate it. There's a vessel which is there.
Dr. Bharathi, this is more like a vascular flap which we are using as a filler. Vis-a-vis when you put the abdominal fat, I have seen in some of the cases, say down 6 months line, that fat gets absorbed and the depression can be felt. So what is your experience?
So that is only because of the malignancy. If at all I am doing in a malignant patient, I use it, sir. In all others, sternocleidomastoid.
Because the fat after 6 months, it goes off. It gets absorbed or whatever it is, metabolized.
The main thing there is to prevent the phrase syndrome. I mean, not phrase exactly. That hollowness, what is there, to fill that we use. What happens is, if at all you put sternocleidomastoid muscle like this, if at all there is a recurrence, it might grow along the sternocleidomastoid down. So we don't want that to happen, sir.
Yeah.
You are taking out one of the natural barriers, you can say.
I mean, like we have seen, not here, in PMMC flap, when we use the recurrence, the chest metastasis, we have seen.
Yes. I will like to share my experience. I have been doing parotid since late 80s. As a general surgeon, we never used any magnification. And we always used to follow the nerve. Main trunk you identify, go along with it. And that gives excellent result. Now with the addition of the magnification, probably our life has become much more easier.
Yeah. It's always better to be safer, sir.
Yes.
Yeah.
So that is a welcome change. Yeah.
Sir, we have done without magnification also in initial phase of a life.
Yeah.
But you cannot see so many branches like this, ramifications. You cannot.
Yes.
You can see 2 branches and 5. That's all.
Right.
But not like this, sir.
And that is something we shouldn't be dogmatic about.
Right. Yes, and no, still, Dr. Prahlada, if you see most of the general surgeons are hardly using any magnification. Maximum, some of the people are using loop. But
that is the magnification for them, sir. They will have 2.5 to 3, whatever power we use.
But I have seen most of the general surgeons, the older generation, they are all using without any magnification.
Yeah, there are some surgeons.
So,
Dr. Shanai from Mauritius is asking, is it, do we have to identify spinal accessory nerve before
no.
incising the...
We are not taking through and through.
Just a superficial flap kind of this thing, sternocleidomastoid. It's like elevated like a flap. It's not complete bulk of the sternocleidomastoid, Dr. Shanai. Yeah. That was fantastic, ma'am. I think, ma'am, you did wonderful job. You demonstrated very well. We have a lot of take-home message, starting from, one is your humbleness. You appreciated all the teachers and all your friends who really helped you to come reach this stage. I think that is one greatness of a person, That is one important take-home message all junior colleagues should take. And second, investigate properly patients. Don't rely on ultrasound alone. You have a tissue diagnosis and proper imaging. That is second thing. Third is use incision wisely, whichever gives best scar and minimal complications in your hand. And identify the patient now. In the ENT surgeon's hand, there should not be facial nerve paralysis at all. Get your anatomy straight and identify the facial nerve. And before that, take patient's consent, proper consent, explain the patient about the possibility of facial paralysis or paresis, whatever this thing. And also if required, a deep lobe, this thing, the consent for deep lobe excision, okay, based on whatever preoperative investigations. And finally, using this sternocleidomastoid flap, I think that is one of the biggest take-home message we have today. Ma'am, really, it was a great honor to have you here on this platform, on this program. And this is one program, we have a lot of international participants. We have from 9 countries today. And really, all are truly blessed to see your work and listen from you, watch your surgery. Thank you very much, ma'am. And also all the participants, thank you very much for being with us. That on a weekend, many people said you change it to a week because weekend is for families, but somehow I am busy during the weekdays. I won't be able to organize this program. So for us, the quality of the audience, which is more important than the quantity of audience. And really, thank you very much. We are really honored to have you. Of course, we still have some more questions. Yeah, but when you say so weekend is the best, and ma'am, lot of appreciations from all the participants. I see a lot of messages. So thank you very much, ma'am. Very well demonstrated. And again, we look forward to have you on again on this program sometime in the future with another surgery. Thank you very much, ma'am, for your time. Yeah.
Thank you, Prahlad. It's actually I'm honored to be with you on sharing the same dais with you. Yeah. And it makes my day. And what I tell is all the conference, you said the teachers, yes, yeah. In all the conferences when I was interested in some topics, I used to sit and listen. And those are also indirectly, they have taught me. Yeah. Because, I'm in Mysore, I'm in a second tier city. Yes. And you know everything about my thing.
Yes, ma'am. Yes.
So all this slowly I studied, and then I used to come back and put my effort. I used to study, and I used to do the surgeries. Yeah. So I think all the youngsters, because nowadays at least they have the YouTubes, they learn. But then also it's a personal one-to-one basis if you learn, no?
Yeah.
It gives you more confidence.
Yeah. Okay.
True, ma'am. To deal with the tissues, to deal with the patient, and to respect your patient. That is one thing which we all should learn, to respect our patient and to do good to the patient and no harm to the patient. At the end of the day, that's the message.
Yeah. I think that's a very important message. Yes, ma'am. Ma'am, before we end the meeting, do we have permission to post this on YouTube? I'm going to hide the identity of the patients, those where we have pictures. Yes, ma'am. Yeah, because a lot of, again, a big number of audience, they will go to this video very keenly. Who couldn't make this meeting for the live. Thank you very much, ma'am. Look forward to have you again with us soon.
Thank you.
Thank you.
Bye. Thanks everyone for spending the Sunday with us. Thank you.
Thanks.